Hello, everyone. I'm John Denstedt, Secretary of the AUA, and I greatly appreciate the opportunity to participate in your meeting. Of course, we all wish that we could be there in person, but with the pandemic situation, of course, we're all still doing virtual meetings, but I greatly appreciate the invitation and the opportunity to contribute. So what we'll talk about in this presentation, it's very interesting to see what's happening with the treatment of kidney stones, where we now have two quite different operations emerging in an almost competitive way to treat many kidney stone problems. So we have flexible ureteroscopy, often called retrograde intrarenal surgery, or RIRS, and in a parallel way, we have mini percutaneous surgery, and both of these operations can often be deployed and used to treat the same kidney stone problem. So we have a bit of a race going on in terms of these two techniques and what will fit in the best and what will provide the best outcomes for our patients. So we'll look a bit at this debate. So if we turn first to our guidelines in treating kidney stones, these are the AUA guidelines, and if we're considering stones smaller than 2 centimeters in the kidney, 20 millimeters, what the guidelines describe for us is that we have two options, either shockwave lithotripsy or flexible ureteroscopy. Stone-free rates are acceptable with both. Both of these are less morbid than standard PCNL. Ureteroscopy probably gives a lower risk of a repeat operation than shockwave, but the advantage of shockwave, of course, very non-invasive. But what we're seeing now in many locations, institutions, is that we have a third option now emerging, and that's mini percutaneous stone removal for these smaller stones up in the kidney. If we consider larger stones, bigger than 2 centimeters in size, what the guidelines say is that percutaneous stone removal is the best treatment option. But in this case, we're now seeing a migration towards flexible ureteroscopy as an option for larger stones. And we'll, again, look at this debate and try and sort out here where these two things fit in. The trend described in this slide, I think, is being seen throughout the world. This happens to be from where I am in Ontario, Canada, from our provincial database, with a very significant decrease in the use of shockwave lithotripsy, the blue line, and a parallel increase in ureteroscopy, which is the red line. So shockwave lithotripsy is being applied in a much less fashion, if you like, across the board for patients, but very significant increase in ureteroscopy. And at the bottom, percutaneous surgery, at least at the time of this study, was about flat. So if we consider first stones bigger than 2 centimeters, generally we would consider percutaneous stone removal the treatment of choice. But what about ureteroscopy? So the best information on this is likely the systematic review and meta-analysis that I'm showing here. So this is use of the flexible ureteroscope and laser lithotripsy for larger stones, so bigger than 2 centimeters. And we can see pretty good stone-free rates there, over 90%. The complication rates acceptable and being low. And in this study, though, what I think the authors did show, if you get into very large stones, bigger than 3 centimeters, you're likely to see more complications and fewer, a smaller stone-free rate. So somewhere here, there's a line, 2.5 to 3 centimeters for the limit, if you like, of flexible ureteroscopy. But nonetheless, it's making inroads even in larger stones. There are certain patients where flexible ureteroscopy for larger stones is perhaps preferred. If you can't get the patient positioned properly for PCNL, if the anatomy prohibits a percutaneous access, and for patients on anticoagulants, ureteroscopy becomes a very good option in those patients. You can leave them anticoagulated for the surgery. This is a busy slide, but we'll just focus on one statistic in the upper right corner. And what this study did was look at the residual fragment rate after ureteroscopy for treating renal stones. And what the group found using CT scans is quite a high incidence, 38% of residual fragments, which I think is much higher than many of us would have anticipated. And this is significant. A parallel study looked at how many of those patients with residual fragments get into clinical problems. And you can see it's as high as 40%, if not higher, will get either symptoms or require some time of intervention. So the goal here should be a stone-free patient, not a patient that's harboring significant residual fragments or they're going to have problems. So the question is, and we're talking now about smaller stones, less than 2 centimeters, how can PCNL be less invasive? There are different ways to do that, improve your access techniques. Miniaturized renal access, though, or mini PCNL, I think provides us the opportunity to make PCNL a less invasive operation. The complications of PERCs, and this is what puts people off doing it for smaller stones, are shown here, with bleeding being the most significant thing that people are concerned about. So a lot of these things can actually be attributed, bleeding and so forth, to the size of the tract. So now we're seeing a variety of descriptions of miniaturized percutaneous surgery. So a standard PERC, 24 French sheath or larger, mini PERC, 14 to 21, and now we're having descriptions of ultra mini and super mini PCNL with very small tracts into the kidneys, down to 10 to 12 French and so forth, as demonstrated in this slide. I give a lot of credit to Janak Desai and others in India, Mahesh Desai, and groups in China for pushing forward mini PCNL. So in this paper, we see mini PERC being applied to smaller stones with excellent stone-free rates, 80 to 90%, and a low rate of complications. A lot of this is being driven by advances in equipment. This is the ultra mini equipment shown here with the sheath size of 13 French and purpose-built instruments for that operation. Numerous companies now are producing a variety of dedicated mini PCNL equipment sets, such as Storz, shown here, Olympus, of course, and others, with 12 French nephroscope and very effective instrumentation. Guohou Zheng in China has described super mini PCNL and purpose-built instruments, which include a sheath that gives you suction at the same time. So fragmentation of the stone with laser and concurrent suction of the fragments in a very minimally invasive operation. Your fragmentation options are pneumatic ultrasound, but most commonly the laser will be the tool that's used to break up stones during mini PCNL. So here we see holmium laser, 365 micron fiber being used in a mini PERC. The goal is to limit the number of fragments and try and get them broken up using a dusting technique so the fragments will come out with a Venturi effect through the sheath that you have in the kidney. So what are some of the indications for mini PERC? These are shown here. I think if you're putting in an upper pole access, stones in chylocele diverticuli, patients in anticoagulants, pediatric patients, of course, represent a great indication. If it's a complex stone location where you may not be able to access the stone with the ureteroscope. But the big question is how does it apply to our standard conventional stones between 1 and 2 centimeters? Just to emphasize the point about children, mini PERC I think is a great option. You're not disrupting as much of the renal parenchyma, of course, and it's a great choice in those patients. So overall, what kind of results can you expect with a mini PCNL? This was an excellent review from the authors shown here, Guido Gusti, Mahesh Desai, and others, and found what they described mini PERC as a very valuable tool, low complication rates with good outcomes, and was cost effective actually, and we'll look at that in a bit more detail compared to flexible ureteroscopy. We do have a few trials that compare the two techniques for treating stones, so flexible ureteroscopy versus a mini PERC. And in this particular study, very similar stone-free rates and operative times, and describing that mini-PERC was very safe and effective for small stones compared to flexible ureteroscopy. Another group looked at the analgesic consumption, patient satisfaction, comparing flexible ureteroscopy to mini-PERC, and found no overall difference in analgesia requirements or patient satisfaction between these two very different operations, and at the same time comparable stone-free rates and complication rates. And finally, an excellent study published fairly recently in the British Journal, International Multicenter Randomized Prospective Study on the use of super mini-PERC compared to flexible ureteroscopy for 1 to 2 centimeter stones, 160 patients, and the results are shown here. There was no difference in OR time, hospital stay, complication rates, or blood transfusion, but the one main difference was a much better stone-free rate in super mini-PERC compared to flexible ureteroscopy, 71% versus 91% for the SMP cases. So just to finish off, we have a systematic review here, looking at the numerous studies now which compare mini PCNL with flexible ureteroscopy. And generally what this has shown is better stone-free rates with a mini PERC, although that comes though with a longer stay typically in the hospital. But very importantly, no significant difference in the complication rates between the two operations. But stone-free rate is really our most important metric here, and that was better with mini PCNL. In a lot of locations, this comes down to cost between these two choices, flexible ureteroscope and mini PERC. This particular study looked at that question in a randomized prospective way and found no overall difference in the total cost between these two different operations. The OR time was higher for mini PERC, but the equipment cost was higher for flexible ureteroscopy, meaning that the whole thing leveled out in their cost comparison. So is mini PERC for all cases? No, it's not. The study, which was an important one, shows us that in terms of stone size, at the moment, you're probably better leaving stones for mini PERC to be smaller than approximately 2.5 centimeters. Be above 2.5 centimeters, the time for the operation, the overall results you achieve in terms of stone-free rates tend to be quite significantly less. So mini PCNL really at the moment is probably confined to stones smaller than 2.5 centimeters as shown here. So the take-home message on mini PCNL, it's certainly a less invasive procedure than standard PCNL. It may facilitate outpatient surgery. There's a decreased risk of bleeding in most studies between mini PERC and standard PCNL. It's not for all stone cases, though. The best outcomes are for stones smaller than 2.5 centimeters. And this generally, I think, is where this operation will fit in. So to go back to the original question, which will win the race, in many cases now, patients can actually be offered both options for, let's say, a 1 centimeter renal pelvic stone. And ultimately, the decision-making is part of shared decision-making between the treating surgeon and the patient. Of course, a lot of this depends on your training experience and equipment. Cost will play a factor in many healthcare environments. In many places, the flexible ureteroscopes and the laser becomes very expensive, the repair costs and so forth. So that encourages a drive to mini PCNL with reusable equipment. And finally, technology improvements in both of these operations. So we have the thulium laser coming, and that's going to drive innovation in flexible ureteroscopy. And other improvements in technology will keep up this race, if you like, towards better outcomes overall for our patients. So I would thank you for your attention. It would be interesting to follow the development of these two techniques over the coming years. And enjoy the rest of your meeting. Thank you.